So actually I'm going to introduce the next speaker. The next speaker is Dr. Doree-Ann Espiritu. She's the interim chair of the Henry Ford Behavioral Health Services and the service chief of psychiatry of the Henry Ford West Bloomfield Hospital. And she's certified in both adult and geriatric psychiatry. In addition to her administrative role, she maintains an active practice seeing adult and geriatric patients in the outpatient setting and in long-term care settings as well. She's a member of the Professional Advisory Board of the Michigan Parkinson Foundation and a member of the Grassroots Advocacy for the American Association of Geriatric Psychiatry. She's received numerous awards, including the Henry Ford Health System Shadow of the Leader, the Dr. Joseph Ponca Caring Physician of the Year, and has been an Our Detroit Top Doc in Psychiatry since 2009. Her special interests are in geriatric psychiatry, dementia, successful aging, behavioral health integration in primary care, non-motor symptoms of Parkinson's, and spirituality in psychiatry. And she'll be talking a little bit about mood disturbances in Parkinson's disease. So let's welcome her.
Good morning, everyone, and thank you, Kevin. I echo the earlier comments on behalf of the Professional Advisory Board of the Michigan Parkinson Foundation. I would like to thank you for your attendance today. I've always have this belief that the patients and caregivers, families and clinical caregivers of Parkinson's disease patients are the most active and most proactive in terms of learning more about the disease, and this is just a testimony of yet another successful, well-attended conference, and so if it's a little tight, we apologize, but this just shows how much there is a thirst for knowledge in Parkinson's disease. So it's always very humbling to follow experts in Parkinson's disease, male neurologists and Dr. Merton. And I'm the first female who's going to speak to you today. But it's also very rewarding to see all of them include psychiatry in terms of their treatment. And so this is a really neat thing going on in this group. So I will be talking about mood disturbances in Parkinson's disease. I'm sure you all know that there's a lot of behavioral symptoms that happened in the group of non-motor symptoms. So I will only focus on depression and anxiety for the sake of time, and all the other behavioral disturbances. Hopefully we'll be able to discuss at the breakout session tonight or in the afternoon. I have no conflicts of interest to disclose, obviously because there's very little research in the psychopharmacology of depression and anxiety in Parkinson's disease. I will be doing a lot of off-label use of pharmaceutical agents. I will tell you when they are off-label, so that I won't get in trouble. So today I will be describing the more common symptoms of mood disorders in Parkinson's disease, like I mentioned, depression and anxiety, so that you will be able to identify the depressive and anxiety symptoms. You will be able to describe the treatment approaches. This is, going to be very broad, but hopefully you will get some insights, some new insights from my talk. Dr. Lewitt talked about James Parkinson's monograph in 1817. So he talked about, all the original stuff that Dr. Parkinson talked about. But he also talked about depression as the cardinal feature in Parkinson's disease, and stated, a more melancholy object I never beheld. So from then on, depression was already such a huge part of, or symptom of Parkinson's disease. Excuse me. So depression in Parkinson's disease occurs in about a half of patients. There is an incomplete understanding of its clinical presentation. There's incomplete understanding of its neuropathology and how best to treat it. It is one of the challenges that we face as clinicians seeing Parkinson's disease patients. The frequency of depression varies depending on the research methodology, the setting, the type of depression that's being studied. For example, is it dysthymia? Is it adjustment disorder? Is it minor depression? Is it subsyndromal? So it depends on those types of depressive symptoms, and obviously also depends on the diagnostic criteria. The criteria is confounded even more so by the symptom overlap, and I will discuss this later in my talk. Majority of epidemiological studies report the prevalence rates go between 20 to 40%, varying between as low as 5% to as high as 75%. But there's more recent studies in community samples and formal diagnostic criteria have been reported that major depression, so if we talk only of major depressive disorder, there's only about 5 to 10%. But if you look at all the other subsyndromal symptoms of depression, that's another 10 to 30%. That's why it's equivalent to half of those patients. Depression in Parkinson's disease is associated with excess disability. It is a huge factor in worsening the quality of life, not just for the patients, but for their caregivers, and causing a lot of caregiver distress. It is also associated with impairment in fine motor skills. They've also found out that there is more rapid progression of motor impairment and disability when patients have depressive symptoms. It increases the development of psychosis. This has been talked about over and over again. If a patient who has Parkinson's disease has depressive symptoms and you're not addressing the depressive symptoms, there is a higher tendency for them to develop psychosis. There's very few studies that looks at, if there's depression in patients who have Parkinson's disease, this also increases their risk of global impairment or dementia. The Global Parkinson's Disease Study Steering Committee concluded that depressive symptoms were the single most important factor in patient quality of life ratings, even ranking ahead of disease severity. And this was published in Movement Disorders in 2002. So, it's very difficult to really dig much deeper into the etiology of depression in a 30-minute talk. So I will just, really simplify it by saying that there are theories related to depression, to the etiology of depression, and they argue that depression either is reactive, which is, an adjustment to all the changes that happen in a patient who gets diagnosed with Parkinson's. So it's almost always like, who wouldn't be depressed, right? I'm slowed down, my family is looking at me funny, my friends, I couldn't even go out and socialize. And, the tendency to blame the disease, and as a result, is depression as a reaction to the disease. It was once thought that depression occurred primarily in the early and the later stages of Parkinson's. And they thought at one time that patients who are in the middle stage of Parkinson's are actually free of depression. These findings supported the hypothesis that the depression in Parkinson's disease could be subdivided into psychological, which is the reactive component, and biological subtypes. The diagnosis of a chronic, progressive, disabling illness, like I said earlier, could lead to depression, psychological nature. While the advanced neurodegeneration, for example, all the symptoms all the biologic outcomes that they described earlier this morning, cell death, dysfunction in neural pathways, neurotransmitter depletion, all those in later stages of Parkinson's disease can cause depression. Some researchers have found that Parkinson's disease patients have more depressive symptoms than patients with other chronic disabling illnesses. So that's, a given. Patients who have COPD, for example, don't have as much depressive illness as those who have Parkinson's disease. Patients who have diabetes, while depression is also high in those patients with diabetes being a chronic illness, they are not as high as those who have Parkinson's disease. From a biological standpoint, the high frequency of depression in Parkinson's disease has been explained by dysfunction in the following brain regions. I don't need to go much deeper in these, but if you look at some of these chemicals, dopamine, norepinephrine, and maybe 5-HIAA, they are decreased in Parkinson's disease and as well are decreased in depression. There is a disproportionate degeneration of dopamine neurons in the ventral tegmental area. One previous PET study found an association between the depressive symptoms and altered basal ganglia metabolism. Another looking at the limbic pathways. Those are things that happen that could also explain depression. Obviously, there's a lot of other non-motor symptoms that could be comorbid when we're looking at, and that we need to pay attention to. So all these conditions, hypothyroidism, testosterone deficiency, homocysteine, vitamin B12 deficiency, they are all associated with patients who have depression, even in patients who don't have Parkinson's, right? So these disorders may go unrecognized as their clinical symptoms overlap with Parkinson's disease. So depression is a common complication of hypothyroidism. But with hypothyroidism, patients manifest with fatigue, flat affect, slowness of movement, poor concentration. Guess what? These are also symptoms in Parkinson's disease. So it's easy to just really not pay attention and think of it as a symptom of symptoms of Parkinson's disease. Some Parkinson's medications may inhibit the thyroid-stimulating hormone in patients with primary hypothyroidism, and they may mask the lab diagnosis early in the disease. So, I'm sure you always do that, to make sure you're also checking with T3 and T4 and not just TSH. And then with testosterone deficiency, it declines with age. We also know that in geriatric psychiatry, it's always one of the things that I also want to look for when I couldn't, really find a trigger for a patient who is presenting with depression later on in life without any other psychosocial factors going on. 20 to 25% of males greater than 60 will show signs of clinical hypogonadism. Again, the symptoms overlap with non-motor symptoms of Parkinson's disease. Decreased enjoyment in life, lack of energy, sexual dysfunction, depression. So those are symptoms of testosterone deficiency, also symptoms in Parkinson's disease. So a preliminary open-label study showed that the testosterone-deficient men with Parkinson's disease who were administered testosterone replacement showed a suggestion of improvement in anxiety scores, verbal fluency, and the part 1 of the UPDRS, which covers psychosis, depression, and cognitive impairment. This was a study in 2002, I believe, by Oken. Some of you will probably say, well, testosterone is, very cyclical in nature, and sometimes even a testosterone level will not be conclusive. But, it's still something that we always want to look for. In terms of homocysteine, this is a byproduct of in the metabolic pathway of levodopa. I shouldn't be lecturing to neurologists about this, but an increased homocysteine levels are correlated with long-term treatment with levodopa and carbidopa. And so it is a complication that can be managed with folic acid supplementation. A recent study in Parkinson's disease patients with increased homocysteine levels were more depressed than patients with normal homocysteine levels. So that's homocysteine, and vitamin B12 is always something that we want to check out for as well. I am going to go over the DSM-5 criteria for a major depressive episode, but always to keep in mind that a lot of the symptoms, a lot of the patients who we will see in our clinics do not really meet criteria for a major depressive disorder. But I still would like to go over them just to make sure, with the DSM-5 criteria, there's really no change from DSM-4. 5 or more of the following symptoms have been present during the same 2-week period and represent a change from previous functioning, so you always make sure you want to ask for the history. At least one of the 2 symptoms should be present. It's either depressed mood, feeling sad, empty, hopeless, helpless, or there should be a loss of interest and pleasure nearly every day, which is anhedonia. And then the other symptoms, significant weight loss when not dieting or weight gain, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, loss of energy, feelings of worthlessness, excessive inappropriate guilt, poor concentration and memory, thoughts of death. And then the symptoms should clinically cause significant distress or impairment in function. And then the criteria C is that it should not be attributable to physiological effects of a substance or another medical condition. So, that's the other complicating factor is, patients do have Parkinson's disease and, they probably will not meet criteria for, not the depression not being attributed to another medical condition. So just a slide to show that the symptoms in depression are, very similar to Parkinson's disease. There's decreased energy in depression. There's fatigue in PD. There's decreased appetite in depression. There's difficulty with eating. So there will be weight loss. There's psychomotor retardation in patients who have depression. There is bradykinesia in Parkinson's disease, so they're also slowed down. Poor sleep in depression. Patients will also have sleep disturbances when they have Parkinson's. Poor motivation, there's apathy, and then poor memory and concentration in patients with depression. Obviously, there's dementia and memory problems in Parkinson's disease. So what are we looking for when we have a patient who has Parkinson's disease in our clinic? Depression feels different. It presents differently. There's higher rate of anxiety. There's higher pessimism, very negative. I can't do it. I can't go one more day. I can't think. There's irrationality. A lot of times, they will give you scenarios that are just so outrageous, and sometimes it's just like, you want to pay attention to those types of comments. In Parkinson's disease patients, they have suicidal ideations, but there's usually no plan or intent. I just wish I wouldn't wake up anymore. Are you going to do anything about this? Or are you going to do anything to facilitate, end your life or kill yourself? And they will say, no, I just wish, I've done this, been there, done that, and, I've really served my, role. I was a good father and good child, and, so there's nothing else for me to do. Those types of comments. But usually when you ask them, they don't want to die yet. They know they still, will continue to live. There's less guilt, and there's also less self-reproach in patients with Parkinson's disease. So in terms of assessment of depression in Parkinson's disease, obviously, we always do this. You need to have a very good history and physical examination. History is always key because past history of depression is a predictor of depression in the Parkinson's disease patient, even if they say they're not depressed. You always want to hone in on what about when you were younger. I heard that you did have some type of depression. Changes in mood and behavior should be assessed within the context of the current Parkinson's disease treatment. I cannot evaluate a patient if I do not know their regimen. That's always one thing. At Henry Ford, at least we're lucky to be able to look on our medical record or call Dr. Schwab and ask. But linking with the community, not knowing what they're taking, not knowing when the changes were done, it makes it very difficult. And then we need to focus on depression and anhedonia, which is, I said earlier, lack of pleasure and interest in things. We always ask the family about the change in baseline. So the armamentarium, all the medications that we use in patients who do not have Parkinson's disease, we use in patients who have Parkinson's disease. So SSRIs, Prozac, Zoloft, Paxil, Celexa, Lexapro, Vibrid. We use non-SSRIs, Wellbutrin, Effexor, Remeron, Cymbalta, tricyclic antidepressants. The results of numerous open-label trials, including the SSRIs and other newer antidepressants in Parkinson's disease, suggest a positive effect and a reasonable tolerability. However, efficacy can only be established through the conduct of placebo-controlled studies, as we all know, and really there has not been a lot of good trials. A meta-analysis in 2013 of randomized placebo-controlled treatment trials for depression and anxiety in PD concluded that there is insufficient evidence to support antidepressant efficacy for SSRIs, for pramipexole, pergolide, and SNRIs, or the Effexors. Tricyclic antidepressants might be the best choice when starting antidepressants because it has most favorable balance between benefits and acceptability, followed by pramipexole and SNRIs, then SSRIs might be the last choice. What do you think about this? Yes, yeah, it's really a very difficult clinical decision to start a elderly patient, on a tricyclic antidepressant. For example, Elavil is used a lot, right? All the anticholinergic side effects that Elavil can cause, constipation, poor vision, dry mouth, even heart issues, can really complicate a patient's treatment if you decide to go for a tricyclic antidepressant. But this is what they found. Another meta-analysis of placebo-controlled treatment trials, I think there were 9 studies in this research, concluded that there remains a lack of controlled trials for both pharmacological and non-pharmacological treatments for depression and anxiety, which limits the conclusions which can be drawn. So really it leaves the decision to us, ultimately. So it is very important that the safety and tolerability of antidepressants in Parkinson's disease be tested in the context of placebo-controlled trials. Continuing with medications, there was a study in pramipexole, Mirapex, and pergolide, which showed that there is some antidepressant effect of Mirapex. Obviously, Selagiline or the MAO inhibitor also has been looked at, which has some antidepressant effects. But there has been concern that the combination of an SSRI, for example, and psilocybin might lead to serotonin syndrome, although clinical experience really doesn't suggest that this is, suggests that this combination is actually safe, because we are not using, an MAO, A, B, non-selective medication. Even psychotherapy, individual and family, we know works in patients who have depression and anxiety, but they have not been well studied in patients who have Parkinson's disease. Electroconvulsive treatment can successfully treat both depression and the non-motor symptoms associated with Parkinson's disease, although motor benefits may also benefit from ECT, but the benefit wears off as the patients go further away from the last treatment. There are 2 open-label trials in transcranial magnetic stimulation, still not as conclusive. Exercise obviously has also been looked at. Then obviously the other treatment modalities, self-management support, and community linkages. So as a guide, your initial drug of choice would still be based on how your patient, how complicated your patient is. They looked at the research. They suggested tricyclic antidepressant would be the first choice. And if indeed you go for a tricyclic antidepressant, I would go for the more benign ones, Pamelor, for example, nortriptyline versus Elavil. The serotonin norepinephrine reuptake inhibitors, which are Effexor and Cymbalta, and then look at SSRI. If not completely effective, we should substitute or add a newer antidepressant. And if there are 2 failed trials, consult your psychiatrist, your friend psychiatrist, call a friend. And then obviously there always has to be a synergy between neurology and psychiatry, and primary care I should include in here, because that will be the only way you can help balancing this whole conundrum. Neurology might go up on the Sinemet, psychiatrist might add Seroquel, primary care might give Benadryl, then the patient is in worse shape. So make sure you communicate. Other considerations I always ask when my patient last took their medication, their Sinemet. It's amazing what you see during a 60-minute evaluation when patient goes to their off period and you can't even get any more information. When they get really slowed down or the tremor gets worse. The caregiver should always be present. Of course, we always give them privacy by talking to the patient first, and then asking for the caregiver to come in later in the session. We need to focus on the non-somatic symptoms. Ask about guilt, ask about helplessness. Because for as long as you're asking about somatic symptoms, sleep, appetite, you will always go back to, these are symptoms of Parkinson's disease. So in summary, depression occurs in approximately half of the patients. It increases motor and cognitive disability and is the primary source of patient and caregiver distress. It is not just a reaction to Parkinson's. It is also biological in nature. Medications can help, but additional research is always needed to validate the diagnostic criteria, to develop tools for screening and establish efficacious treatments. How much time do I have? You're okay? Okay. So we will have time to talk about anxiety. Anxiety disorders like depressive disorders, very common in Parkinson's disease. 60 to 70% of patients have some type of anxiety. It often predates the symptoms of Parkinson's disease. And there were a lot of studies that has looked into this. It is often missed, and the suffering associated with anxiety is often minimized. It is treatable, and it can significantly improve the quality of an individual's life. It is often intertwined with motor symptoms. So again, we make an excuse. They're trembling, they're shaking, they have PD. That's just part of a Parkinson's disease profile. So anxiety predating Parkinson's disease diagnosis, there was a large case control study that showed that the odds of having an anxiety disorder 5, 10, and 20 years prior to the onset of movement disorder was over twice that of those individuals who went on to develop Parkinson's compared to the matched controls. And then there's the study of male healthcare professionals. It's a really huge study with more than 35,000 male healthcare professionals with a 12-year follow-up. And the diagnosis of Parkinson's disease was 1.5 times higher for those who had anxiety compared to those who had low levels of anxiety. So many of these patients that we see have been warriors. They're worried about anything and everything all their lives. And maybe not even worry. Sometimes it's like a perfectionistic tendency. They're very, there's so much attention to detail. They're always anxious about how to plan. These are the types of personality profiles that they've seen in patients before they got diagnosed with Parkinson's disease. So anxiety exerts a deleterious effect on the health-related quality of life of patients, and especially nowadays with the new healthcare arena where we are being measured in terms of all these quality of life metrics, and CMS will ding us for not being able to meet some of these metrics. We really need to look at the role of anxiety in these chronic diseases like Parkinson's. It increases healthcare costs. It causes poor physical health, which is always like a downward spiral. It increases healthcare utilization. They get dissatisfied with services. Sometimes we don't even think of this as a reason why we have low Press-Ganey scores, for example. We keep on looking at, cheerfulness of our staff and, our communication styles, but we're not really, asking what is causing the dissatisfaction. And sometimes it's anxiety, sometimes it's depression. Sometimes we just not talk long enough to ask. There is increased disability, and it is a significant predictor of future cognitive decline. Studies have shown this. So what is the clinical nature of anxiety in patients with Parkinson's disease? Like we said earlier, they're excessively worrying about anything and everything. I think I read in a book, the duck not having, being barefoot, sort of thing, like just not, you worry about the ants, you worry about, things that are not even directly impacting on your life. There's fatigue, more fatigue when patients have anxiety. They have more concentration problems. They're, have a lot of things on their mind. They're difficult to pay attention to detail. They have sleep disturbances. They're more restless than the typical, restlessness in Parkinson's disease. There's increased tremors and there's worsening in function. A study by Dr. Menza and his colleagues looked at what type of anxiety disorders are most common in Parkinson's disease patients, and they saw that 12% of them had panic disorder, 12% had generalized anxiety disorder, Very few had phobias, which for me was, a little surprising because, you see a lot of patients who are very fearful of falling, for example. That's the most common phobia in Parkinson's disease. They have anxiety disorders, not otherwise specified, but 40% of them, they do not meet a specific criteria for a major diagnosis, but they have anxiety symptoms. So I think I also mentioned earlier that half of the patients with anxiety will go undetected. And it's very sad because there was one study that looked at the treatment of depression and anxiety in Parkinson's disease patients, and only a third actually were diagnosed. And out of those third, there's even, I think it's also a third whose treatment is maximized and, optimal treatment of depression and anxiety. So that's how tiny, it is in terms of who actually is following up in terms of the depression and anxiety and making sure they are optimally treated. The other difficulty is measures like the Hamilton anxiety scales. They rate insomnia, concentration, constipation, sweating, and pains as the symptoms of anxiety. Even if we know that these are already part of an uncomplicated Parkinson's disease. There's flushing, dizziness, and urinary frequency. They should not be mistaken as anxiety. So we know that, but we need to focus on excessive worrying. We should start asking more questions if the patient is telling you that they are unable to stop, their mind races because they're worrying about everything. Like depression in Parkinson's disease, there's very few research data. The maximal control of the motor aspects needs to be obtained first and foremost. Make sure you call the neurologist taking care of the patient. Is there anything else we can do to make sure that the tremors are better before you start prescribing a medication? We need to treat the co-occurring depression, use SSRIs, the Zolofts and Celexas of the world, and venlafaxine or Effexor as the first-line pharmacotherapy. Obviously, you can still use other medications like Remeron, mirtazapine, and tricyclic antidepressants, like we talked about in depression. Buspar, there's 2 small studies about it. It's still a good medication for anxiety. It's not addicting, but it really causes a lot of sedation in patients who are of older age, and so it's not easy to use. Benzodiazepines, of course, that's very controversial. Why would you start an Ativan or a Xanax in a patient who has Parkinson's disease when you know that benzodiazepine increases the fall risk and might complicate the cognitive impairment? Seroquel and clozapine, they've been looked at. A lot of us, neurology and geriatric psychiatry, we use Seroquel more because of its, lesser side effect in terms of the motor symptoms. Clozapine, very difficult to use because of its weekly complete blood count and diff requirements. And then there's also studies that looked at gabapentin or Neurontin. Cognitive behavioral therapy, that is the most evidence-based psychotherapy in depression and anxiety in non-Parkinson's disease patients, but unfortunately it hasn't been looked at more rigorously in PD. Exercise, which is of moderate intensity, has also been looked at, and it has shown antidepressant effect. DBS, they've also had some good results, but unfortunately there's also that other complicating factor, which is causing mania and some suicidal ideations in patients who had history of DBS. So anxiety is common in patients with Parkinson's disease, but is overlooked and its impact is minimized. It is associated with poor outcomes, including poor quality of life, not just for our patients, but for caregivers. It causes longer sessions and longer clinic visits, if you've noticed. It's very difficult to, do a visit in 20 or 30 minutes when a patient has anxiety and depression. Treatment is largely unstudied, but clinical guidelines from the geriatric population can be followed. The first step in anxiety disorders is always to optimize treatment of motor symptoms. And then the next step, obviously, is to treat the depression. That's all I have, and if we had time for questions. Questions? Non-pharmacologic? The question about Cinemet and the complication with the interaction with antidepressants or antipsychotics? Antidepressant, where there has not really been, like significant interaction between antidepressants, SSRIs, for example, and Cinemet. There has been some studies that talked about increased tremors in some patients who were on SSRIs, but that's not really that significant in the other studies. Of course, like I said earlier, you don't go psychopharmacology as your first step. You want to look at the best control of the motor symptoms. You want to look at therapy, just coping mechanisms, in patients who have anxiety disorders, meditation, yoga, all these other complementary stuff can be suggested before you dive into chemical. Thank you.